Thank you, Mr. Chairperson. First of all, I would like to thank the organizer for inviting me to share some of our experience that we run in Malaysia. So today I'm going to share with you about spiritual enhancement on drug addiction rehabilitation, or in the short form, we call it SEDAR program. And it's actually the program that using MOS platform as a medication assisted treatment, particularly using methadone in the MOS, in order to expand our methadone program in Malaysia. So this is the background of the studies. For your information, in Malaysia we have somewhere around 300,000 of our populations registered as drug users under the National Drug Agency. This is according to data that we have in year 2006. And out of this one registered drug user, we have another 3 outside, which is not registered. So that means we have more than 1 million of our populations, out of 28 million population, total population in our country, as a drug users. And in our country, we have a harm reduction program, mainly driven by the increasing prevalence of HIV/AIDS among drug users. In year 2010, our Malaysian AIDS Council has reported that we have somewhere around 90,000 of drug users actually having HIV/AIDS, contracted HIV/AIDS, and they are actually sharing needles. That is one of the most reasons why this HIV spread among drug users. And in year 2005, we have implemented harm reduction program using methadone maintenance therapy, and also needle syringes action program in order to combat this rising HIV prevalence among drug users. We have conducted the first national pilot methadone program in the country, where we see very promising results. We see 90% of drug users actually retain in treatment after 1 year. So this is opposite to what we have been practicing for the last 20 years. In the past, we used total abstinence approach, where the numbers of drug users who remain in treatment is actually less than 10%. However, even though we have a very promising harm reduction program, but the rate of expansion of this program in the country is pretty slow. The reason is because of the limited resources that we have. We have a very limited numbers of clinics and also hospitals running this national methadone program. So therefore, we need to actually find a new platform in order to reach our mission, which is by the year 2015, we want somewhere around 72,000 of our drug users to be in the methadone maintenance program. So what are the rationale of starting the methadone program in the MOS? Number one is we want to serve a new platform for the methadone upscaling, and we want to see whether this methadone program is feasible to be carried out in the MOS platform. And number two rationale is to provide integrated medical and psycho-spiritual treatment in the MOS for better outcome in terms of their drug use, in terms of their medical condition. And we would like also to empower the religious communities, the imams, and the carrier of the MOS to be part of the team in the treatment program itself. And we want to attract general practitioners who are actually trained but reluctant to start a methadone program in their premises. In Malaysia, those doctors who actually started the methadone program, sometimes they also receive very bad impression and stigma, being stigmatized by the society. Sometimes they've been labeled as a legal drug pushers and so on. So although many of them have been trained, but they're still quite reluctant to start the methadone program in their clinic. So we invite them to come to the MOS and to collaborate with the MOS people to carry out this methadone program using MOS platform. So we actually carry out a study just to see whether this MOS platform, is it a feasible place to carry out the methadone program. So the aim of the study, we want to investigate the outcomes of the methadone maintenance therapy program in the MOS platform. We actually choose one of the MOS situated at the city center in Kuala Lumpur, Ar-Rahman MOS. And we compare this Ar-Rahman cohort with the cohort from the standard methadone treatment in the hospital, in the university hospital setting. So all the patients, in terms of selection criteria, we use only Muslim patients who are fulfill the criteria for heroin dependent syndrome in according to the DSM-4. The subjects were actually assessed as baseline 6 months and also 12 months for addiction outcomes, and as well as the spiritual outcomes. We use mini internationals neuropsychiatric interview, or mini. We also use opiate treatment index to assess the addiction outcomes, as well as WHO quality of life, to see their quality of life. We also use Hatta Islamic religiosity scales in order to measure the spiritual improvement over time. I would like to explain more with regards to what are the spiritual intervention that we give to these patients. So we give what we call brief spiritual intervention, given by the most staff on top of a standard methadone treatment counseling. So this brief spiritual intervention include washing body part with water or in wudu, praying in the mosque or tahiyatul masjid, 2 rakaats, and recite dua in the mosque environment prior to see doctors to receive their methadone in the mosque itself. So assessment were carried out during the baseline when they first come in, at 6 months and also at 12 months, in terms of their retention rate in treatment after 1 year, their percentage for urine negative over a period of time they're receiving treatment in the mosque, as well as the drug use and HIV risk behavior, and also quality of life and spiritual outcomes. So the result, so this is the result of the study. We actually includes about 64 subjects. All of them is actually males and they are Muslims. They actually been enrolled from the methadone waiting list from the hospital side. So they are actually, in terms of their motivation, they are volunteer to be into the program in the first place. The mean age of opiate addicts who actually coming into the program is about 38 years old. Majority, 64% are singles, and majority actually completed their O-levels and employed at the end of 1 year. We have seen 90% after 1 year, even though before that, almost 100% are not working when they come in. And 70% out of this achieve full employment, they achieve this employment, they are actually doing full-time job. And in terms of their medical status or their medical conditions, we have 55% of our clients or patients hepatitis C positive when they begin the program. Hepatitis B positive is about 3%. We are lucky in our country, we have this mass vaccination against hepatitis B. We also have around 6% who are also HIV positive. And we measure the psychiatric comorbidity. We found that 40% of our subjects who actually enroll into the program, they fulfill at least one diagnosis of psychiatric disorder, particularly anxiety and depressions. Most of our patients, when we start the methadone, we start at the dose of 30 mg daily, and majority of them achieve optimal dosage, which is around somewhere around 100 mg daily. So this just to show the 1 year retention rate between the two groups, the MOS group and also the hospital group or UMCAS groups. UMCAS is actually our center, University Malaya Center for Addiction Science. We carry out the methadone clinic at the hospital setting. So if you see the 1 year retention rate between these two groups, you see almost comparable. It's about 80% of our patients remain in treatment after 1 year, both in the MOS group as well as in the hospital setting. With regards to the urines negative over time, when they first come in, we see a majority of patients. If you see in the hospital setting, 60% is actually urine positive, but when they 60% is actually urine negative, but at the end of 6 months, you can see almost 100% urine negative. So same as a group from the mosque, even though we see less number of patients who are actually urine positive when they start going into the treatment, because before they come into the mosque program, they already started methadone in the private setting. So that's why their urine is actually negative when the time they actually go into the treatment in the first place. But you can see at the end of the 6 months, there is also 100% urine negative. In terms of drug use behavior, the mean score, if you compare between the mosque group and also the hospital group, you can see it's about the same. Almost less than 10% of our patients from these two groups, actually the reduction of mean score means a better condition in terms of their drug use behavior. It's actually comparable. Sexual risk behavior, we see this is actually something that I also couldn't explain why the most group have higher score in terms of sexual risk behavior. The only reason that I can actually postulate here, we have a lacking in terms of sexual risk intervention in the MOS platform. We do invite people from National Aid Council to give sex education, but the most authorities kind of reluctant to accept this group of people because the one that they send is actually not a true guy. It's actually bisexuals, gay. In terms of social functioning, if you see both of this group, MOS and even the hospital setting, there is a reduction in terms of their score, mean score. That the reduction of mean score means they have better social functioning. So, and it's actually comparable among the two groups from baseline to 12 months. Same as crime rate, even though you see UMCAS, I mean the hospital setting have a lower crime rate mean score as compared to the MOS group, but these differences is not actually really significant in terms of the statistical test. Same as a general health condition, if you can see here, there is a reduction of the mean score. That means they have a better general health condition over 1 year periods, and the both group is actually comparable. In terms of quality of life, the mean score, we actually take the total quality of life as our cutoff point, and we see that the both groups, there was no significant difference, and actually both groups have shown improvement in terms of their quality of life over time. In terms of the spiritual improvement, we found that group from the MOS, even though when they start, they have a lower score in terms of their mean score, but at the end of one year, you can see they actually catch up and they achieve a good improvement in terms of their spiritual outcomes. So the result, we can conclude that there was no significant difference between the two groups in terms of socio-demographic profile, their medical comorbidities, as well as psychiatric comorbidity, doses of the methadone, addiction outcome, and spiritual outcome. Okay. However, this study has several limitations. We only have very small samples in terms of numbers of subjects actually going into this program. Therefore, it's actually limit for the statistical test for significant finding. Some data only rely from the report from the patient. We don't have enough collateral history from the relative as well as from their significant others. As you can see here, the brief spiritual intervention are only monitored during the induction phase. That means first 3 months. After 3 months, majority of patients, they start working. When they start working, they cannot actually come to the mosque every day, and we cannot actually force them to do all these rituals. So we actually encourage them to do outside, nearby their workplace as well as their home. And for your information, we actually carry out a randomized control trial. This is not randomized control trial. It's just we are not doing randomization at the beginning of the study. But now we actually expand this research. We carry out the randomized control trial now is undergoing in different mosques. Okay, we have 12 defaulters at the end of 1 year. A majority drop out during the first few weeks of the treatment program. Some participants are caught by the police due to the old petty crime and also because of the urine drugs positive. The reason why they get caught, not because they're taking methadone. We have a very good understanding with the police, but they've been caught because of their old crime Last time, quite difficult for the police to catch them, but when they go into the methadone treatment, they become centralized. It becomes easy to the police to catch them. The police just wait in front of the methadone clinic in the mosque. Okay, so these are some of the pictures that I'd like to share. This is Masjid Ar-Rahman, the place where we actually carried out the first methadone program in the mosque. Before we actually start the program, we have a very hard time to convince the religious leaders and the community. The reason is because at one time, the religious leaders actually say, give a fatwa that methadone is haram, without their understanding what are the purpose of using methadone. We have tried our best, and lastly, we are able to convince them, and they actually allow and offer the place to start the pilot project of methadone treatment in the mosque itself. So this is the entrance of the methadone clinic in the mosque. We actually set up the clinic inside the mosque at the first floor. We have a clinic there. It's a very simple setting of the clinic. We only use the curtain. We don't have walls. Therefore, the mosque place still can be used for the praying. And we do all the physical examination, taking the full history. We involve the students to take part. And the dots, direct observed therapy by pharmacists is actually taken place in the mosque itself. We give the methadone in the mosque. So this is the picture of one of the patients take methadone in front of the pharmacist. And for your information, the methadone was actually not being given take-away dosage. We actually asked them to come every day. The clinic opened up from 9 o'clock in the morning until 12 o'clock. And after that, we close the clinic. The patient go back and they continue their function in the society. So this is at the end of 1 year. If you can see, most of the patients, when they come in, they are very, very dirty, poor hygiene. But at the end, 1 year program, they are actually very clean. They expect as their doctors who are actually providing treatment. So in conclusion, we found that the methadone treatment in mosque setting is feasible to increase coverage of methadone in Malaysia and comparable with standard methadone program in the hospitals in terms of outcome measures, addiction. The most MMT program is potential to improve the spiritual levels and also improve the outcome of the addiction treatment among the methadone clients. There is a need for further study to investigate the effectiveness of integrated medical and spiritual treatment in mosques with larger sample, for example, like randomized control trial, and also to include study with qualitative aspect to find more about the outcome measures. So the progress of the SEDAR program, we actually has been approached by the New York Times. They actually published about this program in year 2011, as well as we received feedback from the WHO report 2011 as a first world methadone program and among best practice in Asia. We expanded the program to a few other mosques, and we are planning to cover 1/3 of the mosques in Malaysia. We have around 6,000 mosques in Malaysia. We hope we can cover 2,000, and we can help our government to achieve 72,000 of our drug addicts to be in the methadone program by the year 2015, hopefully. So these are the articles in New York Times that I mentioned. The pilot project has already been published in Journal of Drug Policy. If you want, you can actually go to the website and just see our first articles. This is we also have a video in the Al Jazeera TV. You just download this video tube, put Google's MOS and also the methadone, it can come out in the. So with that, thank you very much for your attention.